Next, Dr. Nimmy George will be talking on effects of long-term topical anti-glaucoma medications on dry eye syndrome.
Good morning, dear judges and audience. The topic of my study is effects of long-term topical anti-glaucoma medications on dry eye syndrome. Topical medications form the current first-line therapy for glaucoma because of its wide acceptance, but it can profoundly affect the tear film stability. The dry eye disease is one of the most prevalent eye conditions with an Indian prevalence of 32%, and iatrogenic causes like ocular surgery and topical medications are well proven. GOISD, or the glaucoma-related ocular surface disease, is a significant yet often underdiagnosed ocular comorbidity affecting nearly 60% of the glaucoma patients worldwide. The topical therapy can cause tear film abnormalities and instability of the ocular surface, which can adversely impact the patient compliance with therapy and overall quality of life. A word about LipiView. It's a novel investigation for dry eye. It operates on the principle of white light interferometry. It gives an objective assessment of the tear film blink dynamics, that is, it gives blink patterns and also a partial blink rate, and it also allows visualization of the meibomian glands. From LipiView, we get a value of LLT, that is lipid layer thickness, which when less than 60 nanometers is indicative of dry eye, and also we will get a partial blink rate, which when is more than 50% indicative of dry eye. Moving to my study proper, it was a cross-sectional study done over a period of 2 months in the age group of 50 to 75 years. I considered 110 eyes of 55 patients on AGM of any category for at least 1 year, and then I compared it with 98 eyes of 49 controls. I excluded patients who were who had previous history of ocular surgeries other than cataract surgery, those with a past history of dry eye, those who were using other topical medications, and who had history of systemic conditions like Sjogren's syndrome or rheumatoid arthritis, which can predispose to dry eye. A questionnaire of symptoms were asked and a score out of 7 was given. T-BERT and Shimmer 1 test were performed for each eye. From LipiView, meibomian glands were visualized and meibomian gland dropout was graded from grade 1 to grade 4, as can be seen from the images, and also we obtained LLT, that is lipid layer thickness, and partial blink rate values for each eye. Moving to the results, the females predominated my study by 61%. Prostaglandin analog was the most commonly used anti-glaucoma medication, and burning sensation was the most reported symptom. Compared to controls, the cases, that is the eyes on AGM anti-glaucoma medications, had increased symptom score, increased MG dropout, reduced lipid layer thickness, and increased partial blink rate, all of which are indicating of dry eye more in eyes on anti-glaucoma medications, and all these were statistically significant too. But a correlation between the number of AGM and dry eye parameters, I could see that with increasing number of AGM, there was increasing MG dropout, reduced LLT, and increased partial blink rate. This is a bar diagram showing the same. As we can see here, with increasing number of AGM, there were higher grades of MG dropout. Next, a correlation between the duration of AGM usage and dry eye parameters. With longer duration of AGM, there were higher grades of MG dropout, reduced LLT, and reduced shimmer, which were statistically significant. I also did a comparison between the individual AGM on patients who were on monotherapy. I compared beta blockers, carbonic anhydrase inhibitors, and prostaglandin analogs. The mean duration was almost similar in the 3 groups. I could see that the PG analog group had increased MG dropout, reduced LLT, increased partial blink rate, and reduced T-BERT and shimmer. Moving to discussion, the difference in MG dropout score, partial blink rate, LLT, T-BOT and shimmer values were explicit between the eyes treated with AGM and control eyes, which was similar to other previous studies. In the three monotherapy groups, the mean duration of the drops were almost similar, which might be the cause for lack of a significant difference in the dry eye parameters among the three groups. Also, we know the meibomian glands secrete lipids into the tear film, which contributes to tear stability and which is self-explanatory of the increased MG dropout eyes had a reduced T-BOT, which is seen in my study too. Study had limitations. Age and gender were major confounding factors because perimenopausal female are already predisposed for dry eye. The state of meibomian glands before the start of treatment was not known, so we are not sure about the pre-existing status of the meibomian glands. And the effects of AGM and preservatives could not be investigated separately, as I didn't study any preservative-free drops. So to conclude, a long-term AGM usage can cause dry eye and our study supports the same. To the best of our knowledge, this is the first study of its kind done in our population. Prescribing minimum number of AGM to achieve target IOP can help in reducing the glaucoma-related ocular surface disease, and which will definitely improve patient compliance to these medications, which in turn will reduce the progression of this potentially blinding illness. Thank you.
The main cause for ocular surface disorder is due to preservative. So is it necessary to see the preservative?
Yes, ma'am. We are planning a prospective study comparing difference between preserved and preservative-free drops. Prospective study would be better.
Yeah, so that is the, because we all know the ocular surface is affected mainly because of the
Preservatives, BAK.
preservative, BAK. Okay, that is not, you have not
I have not
included
considered.
that.
No.
Yeah, your study would have been 3 times better if you had categorized the medicine. That is the idea. So, between clinical evaluation, where we don't have the lipid view, and this, you say it is far more superior. But some one place you say this no dropout was nothing, but you had a T-BOT which was reduced. One of your statements, no? You found that also?
I know, sir. It was correlating. Sir,
Correlating.
with increasing MG dropout, there was reduced T-BOT.
Okay. So it is all in lines with the existing studies, no?
Yeah, yes.
You have
Yes,
not
sir.
shown all the studies.
Existing studies also between individual drugs. Very few studies have compared.
No, did you show the studies in your
No,
presentation?
only
No,
just only
just
references.
mentioned. Thank you, ma. Good presentation.